Oh, hey, Chris.
Hey Chuck, how are you?
I'm good. I feel like you and we've seen each other a bit lately, but not in the confines of our own homes and during a podcast taping.
Yeah, we've had a fair bit of interaction. It's that kind of year. I mean, that time of the year where graduation season. All the fond memories and the welcomings and goodbyes are in the air.
Absolutely. We had a wonderful graduation ceremony and graduation speaker, Val Lewis from MD Anderson came up to spend the weekend with us, and she was wonderful as a speaker and was there for our graduation ceremonies last night, at which time you were awarded quite a special award.
It was quite surprising, to be honest with you. I don't know a terrible amount about the award, except I know that there are some great people that I admire tremendously who have received it in the past. But it's the I don't know if I'm going to say this properly, but the Palma Coronis,
I've always said Palma Sharonis.
Sharonis,
But
like my
basically
Sharona.
it's basically teacher of the year in the sense of and that's a simplistic way of saying it. But faculty member with the greatest impact on the education of the Chiefs. And it's it really is a great honor. So that's awesome.
It's things that I learned in being awarded it is apparently I sigh quite a bit, and I also make our trainees, especially this class of Chiefs, apparently draw the brachial plexus. So I think that two of my mentors, Marty Boyer and Scott Wolf, have had an outsized impact on how I educate in terms of sighing and drawing the brachial plexus.
Marty is the king of the sigh, and Scott must be the king of the drawing of the brachial plexus. But that is very funny, and it absolutely was cited in your award recognition speech.
Well, it's a tremendous honor, and this group of Chiefs has been fantastic, and I actually did work with pretty much all of them in during their clinical rotations for hand, and I'm glad that some old school techniques are still very effective, but I have kind of adapted myself to the current generation of learners, as I think we all have.
That was cited as one of the reasons for your award. And our department is really filled with amazing educators, and it is again quite an honor for you to join the crowd of those who have won this. So cool. Um, you've been traveling. Where have you been lately?
Well, you heard we did the live episode from Singapore, and then I was at the AOA, the American Orthopedic Association meeting in Salt Lake City, in which you, as the program chair, put together a fantastic program. So I was just about to ask you to tell us about that experience and congratulate you. By all accounts, just like the congenital meeting that you put together with Anne Van Heest and Michelle, this was also a great success.
Yeah, it's great that it's over. I think I was pleased with the meeting, and we had some great content. Um, I will say that for me, the highlight was, for those who aren't aware, Preston Phillips was killed in clinic a little more than a year ago in Tulsa, Oklahoma. Preston was an impactful AOA member of multiple different societies. Um, African American orthopedic surgeon, of which there are far too few. And when he was shot in clinic and killed, it really was not that we needed a wake up, but a little bit of a wake up on the role of the orthopedic surgeon in advocacy around gun violence. And it is highly controversial. And there are plenty of members of the American Academy of Orthopedic Surgeons who want nothing to do with this, and in fact think we should quote unquote stay in our lane. So, anyways, as a result of that, we put a symposium on about gun violence, and it was really, really good. And Anna Miller from St. Louis really used the city of St. Louis and some of our challenges as a case study, which also was an impactful part of it. So I love that one. I love them all, but that symposium for me was perhaps most impactful.
Yeah, it's very a sad state of affairs in the U.S. with regards to the epidemic of gun violence, and our listeners in the U.S. know that, and those that are listening and have kind of viewed the U.S. from outside clearly know that it's very different here than it is everywhere else in the world. That being said, it is a huge problem, and I think that the challenges that we face is that orthopedic surgeons traditionally, both individually, but also as a group, have shied away from this. One of the issues, to be very frank, that I've had with working on advocacy through the AAOS, which I've done in the past, as doing lobbying, doing the Washington Health Policy Fellowship, being Government Affairs Committee Chair for the Hand Society, interacting with the AAOS, is that they have really stayed away from this because the membership of the AOS has wanted to kind of stay in our lane. As a comparison, the American College of Surgeons has jumped in on this, which I do admire tremendously. So hopefully there'll be a sea change, and obviously the tragic events that happened to Dr. Phillips maybe contributing to that change in opinion. But it's something that needs to be addressed. We've done some research here. Our lab has done some work on, the epidemic of gun violence, especially during the pandemic. And I'm sure Anna showed some of those slides. And it's actually an area of research that we're looking into doing some grants and everything for looking at gun violence and how it relates to nerve injuries and upper extremity trauma in general. So, yeah, that was a very impactful symposium for sure. And I think it'll, stimulate a lot of future discussion.
Yeah, well said. And great AO meeting. I was privileged to be Wayne Sebastianelli's program chair, and happy that it went so well. I'll segue from that to saying that it's interesting because when I was a resident all those years ago, yes, there were cars, and much of our level 1 trauma center work was based around motor vehicle crashes, motorcycle, and occasionally other stuff. Certainly some gun violence, but not much. Today, I would say, while we still have those, thankfully, in a weird way, we have a lot of gunshot wounds to deal with as an orthopedic service, and we also have a lot of infections related to drug abuse. I was fortunate recently to be the graduation speaker for University of Florida, and I learned a little bit about a new I guess, drug combination, which is wreaking havoc. I'm not sure if you've heard of this. It's a animal tranquilizer it's called xylazine, and affectionately, it's the wrong word, affectionately known as trank. But trank is mixed with fentanyl because fentanyl alone apparently does not give the desired high. Or maybe it's just a little different. So if you mix the two together, the high is different or better. The trank is unbelievably brutal on the extremities and often leads to a ton of dead tissue and amputations. Have you had any experience with trank?
Not in any capacity, if you're wondering. But so no, I've only I've heard of this just kind of listening to the general news on podcasts and everything too. It's terrible. And it's really sad that kind of we're going through this. And I think the etiology of injuries has certainly changed from when you were a resident in the 90s to where we are now. I'm just going to put that out there. You were a resident in the 90s.
The
You've been in
1990s,
you've been
1990s.
you've been in practice longer than most people who listen to this podcast have been alive. But yeah, it's awful. I think that it's going to continue to change. I can't see things getting better appreciably, but we should probably talk about something a little more lighthearted on this podcast.
For sure. But I also think it's something we see. And yeah, I'm not looking to solve the drug epidemic and the gun violence epidemic today with you. So let's talk about something more fun. What do you got up your sleeve?
Well, I will. So I want to make this brief because we've got some good cases to talk about. We are currently in the midst in this household of planning our first camping trip. And no, my wife is not coming because she doesn't get down with that. So it is a father-son trip. A couple of families, Dr. Wall's son and her husband are coming. And he's got all the gear, which is good. But I just want to put a quick plug out there. If anybody has any camping tips, please feel free to share them because we're about to embark on quite the adventure.
Is this July 4th weekend camping trip?
No, it's the weekend afterwards.
Wow, so you are really good. You had the father-son fishing trip with Dr. Burks, and now
Yep.
I assume Dr. Burks is going to join for the camping along with Dr. Wall's family. Wow.
It's going to be quite the trip. I think that my son has been watching too much Outdoor Boys YouTube channel because he knows all the product plugs that they have, and he wants to go to Bass Pro and just go nuts. So
That is really
it's
funny.
gonna be the most expensive camping trip in history. But if anybody has any tips, let us know. And then please feel free to email me directly with those. But we should probably shout out our sponsor, Practice Link, before we get in these cases.
Absolutely. The upper link, I'm sorry, I'll cut that out. The Upper Hand is sponsored by practicelink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join Practice Link for free today at www.practicelink.com/theupperhand.
Hey, Chris,
Hey, Chuck.
do you have any reviews to share?
I do actually. We have some great reviews to share. So we've had a couple that have come in recently. We are still at 4.9 out of 5. So somebody gave us 1 star, somebody gave us 2 stars. So we need more 5-star reviews to try and drag that average up. I don't know how the iTunes systems works in terms of rounding up. But we recently got one from Skating Lady that says 5 stars, great for wannabe CHTs. I'm an OT practicing in hand upper extremity rehab, preparing for the CHT. I really enjoy this podcast as it gives great insight and detail into the surgical procedures I treat. She appreciates how we respect and appreciate our therapy colleagues. And so thank you, Skating Lady, for that review.
Yeah, thank you so much. We are a little bit on a therapist hiatus given the maternity leave of one of our wonderful therapists, but we need to get back to it.
We certainly do. I think that those episodes are always big favorites. So I look forward to having Macy come back on and maybe even some other therapists. So the next review is from Pod Enthused, 5 stars, and it says lovely for trainees. I'm a PGY2 in ortho, hoping to be a hand surgeon. These episodes have been hugely helpful for the nuances of surgical technique that there simply isn't enough time to discuss in the OR. Also enjoys our discussion about patient factors and indications. So thank you to Pod Enthused for listening and for leaving a review. And make sure that you get on there and leave a review. You can even sneak a question for Chuck in there about all of his fancy athlete work and all that kind of thing.
Yes, please, please, please do. And we had a great email from one of our listeners, Joe Rosenbaum, who shared with us that he was thrilled to hear us discuss Israeli baseball because Joe, I guess, was professional or semi-professional. I don't want to offend him by the wrong terminology, but I'm impressed that he played that high-level baseball and it wasn't in the United States.
That is really impressive. Baseball's hard. I think baseball's hard. I've learned, I think I talked about this in one of the other podcasts when I was coach pitching for my son's first grade baseball games, and I definitely threw the ball in a manner in which there were some children that were hit. Now I spread it out among all of the children on our team that got beaned by the coach, but I have a greater appreciation for baseball now.
Baseball is hard. There is no doubt. And baseball's better this year. It's the pace is faster. It's a little more exciting. So that's good news. All right. We had talked about maybe talking about some current trends in orthopedics and medicine using some journal club articles to further discuss.
Yeah, we should do the journal club articles. I want to talk about a case because we haven't talked about a case in a while. And I think this one kind of piggybacks on our last discussion about age. So I've been following a patient for probably about 3 or 4 months now who is, you know, somewhere between 55 and 65, and is somebody who uses his hands quite a bit.
A young
And
man, a young man.
a young strapping lad,
Thank you.
non-Medicare eligible, uh, so under 65, but uses his hands quite a bit, and doesn't like to cannot stomach the thought of prolonged immobilization. So when I first meet him, he comes in and he had a fall onto his wrist and has a scaphoid waist fracture that is displaced, but not severely angulated, kind of well aligned. If you gave it a chance to heal in a cast, it probably would heal in a cast. And doesn't have any arthritic change or anything like that. It's a recent injury. And we talked about treatment options, and given that he uses his hands quite a bit, even though he was not, a very young person, I thought it would be very reasonable to discuss surgery.
I think in today's society, the speed at which we can get patients back to activities is really important to them. And so I think it's fair to discuss surgery. Now, I will quibble with one thing you said, or maybe it's just how it came out. You said it was a displaced fracture, at least minimally. And for me, that a displaced fracture that one can determine on X-ray really does mean it is displaced, and that does decrease the chance of healing, which is, in my mind, yet another reason for surgery.
Right, right. So I think that the amount of displacement, especially for a scaphoid fracture, I think that we all kind of debate about how much could heal versus, not heal with the cast versus surgery. I think especially for scaphoids, definitely tilts you towards surgery. Do you think that for scaphoids in particular, surgery speeds the recovery that much? We know that, surgery will shave off a lot of time on recovery for distal radius fractures, and we'll talk about that in some of the articles we discuss. But do you think that scaphoids, you save a ton of time?
I think it depends on how you define time. So I do believe it will decrease the amount of immobilization or the time duration of immobilization. And the only article I know of, and if a listener knows of another article, Chris, or obviously if you know of another article, let us know. But way back, the Shin article, Bond is the first author, Shin's the second author, compared ORF versus cast immobilization. And basically it showed that it shaved a week to a week and a half off of the healing time. And so to me, that's not a great deal. If you're living in a cast for a while, I think you probably think it's a helpful amount of time, but I don't think it saves a ton of time for the overall healing, but it does just get you going faster. So that the way I say this to my patients is, if we can start your rehab, start your therapy safely sooner, while it may not dramatically change the time to bony union, it'll decrease the time of overall recovery because you're healing and working on motion at the same time.
Yeah, I agree with that. I think that, the numbers that I was taught, I remember Dr. Gelberman in clinic talking to patients and, telling patients that, after fixation, screw fixation, you're still looking at 6 to 8 weeks of immobilization before he felt comfortable moving the patient to the next step of motion. And, with a minimally displaced fracture and treating it in the cast, you're looking at 10 to 12 weeks for that bone to heal, which is much longer than, the standard 6 weeks or orthopedic unit you would get for any other bone. I think that the where you can save time in terms of immobilization really depends on the surgeon's threshold for allowing discontinuation of immobilization. That was a very wordy way of saying it, but when do you feel comfortable, if you've got solid fixation, when do you feel comfortable letting the patient start motion?
Yeah, I think that's exactly right. And there is no literature to guide us on this whatsoever. And so, there's a big difference in healing time between proximal pole, waist, and distal pole. And my interpretation of literature, which supplements what you said about Dr. Gelberman's protocol, essentially a proximal pole treated non-surgically is 10 to 12 weeks, sometimes 14 weeks. Waist to me is 8 to 10 is what I quote patients, and 6 to 8 for distal kind of pole or distal waist. I have a pretty firm protocol post-surgically, whether it be proximal pole or waist, of about 5 to 6 weeks in a cast, and then I shift to therapy with a custom fabricated thumb spica IP-free splint and early motion, initially active and gentle passive, progressing from there. What do you do?
Pretty similar. We know that when you do motion for wrist, is it you said active only, no passive. We know that the dart thrower's motion is good for the SL ligament. Do you think that can be extrapolated to less stress on the scaphoid bone itself?
I don't know that to be a fact, but I do, to be very clear, the instructions to the therapist. And again, when you have a trust level with the therapist, it really is helpful. So active for sure. And I'm okay with some gentle passive motion to start, especially if they're doing therapy in the system that I know. If they're at an outlying therapist who I don't know, then I'm a little more hesitant and may do active only.
Right. Right. And then I guess you said there was no literature to guide us. I agree. There's no good clinical literature. I think the paper that I go back to a lot is more of a biomechanical one. In terms of looking at load to failure on a scaphoid, the intact scaphoid versus one that's got an osteotomy line of 50%, 75%, 25%, and then with or without screw fixation. And I think that the threshold for me is if I appreciate, probably about 50% of bony healing with the screw in place, then I'm more comfortable treating it as if it was healed, um, even without full bony consolidation.
I think that's a really important point. And number one, you got to get a CT scan to be able to quantify healing. And I've actually even dropped that number a little lower. I think occasionally you'll see like 10%. To me, that's not enough. 20%, probably not enough. But once you get past 30 to certainly 40% with a screw, I'll let them go. And knock on wood, I've never regretted it.
Yeah, I think that a lot of times some of our radiology colleagues don't appreciate what we're trying to do when we get this CT scan, and they tell us that the bone isn't healed yet, so I tend to scrutinize these and see what I feel comfortable getting away with. I'm certainly not the best at quantifying these things, and there's probably room for improvement in our communication with the radiology team. But I really look at it, and if I got to feel comfortable knowing that this is well on its way to healing. Um, so yeah, those are the concerns I have. But to bring it back to this case, I actually did recommend surgery for this patient, and he declined. So then we tried cast immobilization, which the patient did not comply with. So we decided at some point to say, all right, if you don't want to wear a cast or do any immobilization, and I'm certainly not going to operate on you if you're not going to be okay with immobilization, so we're just going to let this ride. And at that age, are you okay with saying, all right, you get a snack wrist when you get a snack wrist?
Well, I was going to say this is sort of a natural history study because we have some natural history knowledge from way back when. It would be great if you could keep us if the podcast is still going on in 10 years, it'd be great for an update. But
Well,
yeah, I
I
think
don't know. When do you think this? When do you think this? Maybe it's different than a slack wrist. Maybe it's different. So scapholunate ligament injuries leading to post-traumatic arthritis versus a scaphoid nonunion. There's the paper, I believe the first author was Mack, that described as progression to arthritis. But I think what we still don't know is how long exactly it takes to get there. We know it's going to happen at some point, and it seems to be the progression to arthritis, to post-traumatic arthritis, is highly variable. And most patients eventually do get there, but I don't know what that timeline is. How do you counsel patients about that?
well, just to follow up what you said, it was Mack, and Gellerman, and to make us all feel really old, or at least me, it was from 1984. And so, that's a lot. And I honestly think it's 10 to 20 years. But I don't know, thankfully, at least in my patient population, most would choose proactive surgery. But I think it's a while. And so, 55 is, I think you say it was 55 is not
It's
old. And
young. It's young,
it's
right,
young.
Chuck?
I'm not there yet, but it is young. So yeah, I think it's fine. And look, he's made his choice, and so we'll see what happens. And then, if let's say he does come back and he's having pain, he could be a candidate for distal pole excision only, without doing a more significant operation.
So he comes back because he
Oh,
fell
he's
again.
already back.
Because he fell again, and his scaphoid fracture is still displaced but not angulated in the sagittal plane. Uh, do you have the same conversation again? Now his wife's with him, so she's there to cajole him and talk to him about what the options are. How do you counsel this patient now? He does, and he's not developed any arthritis, which of course you wouldn't expect in such a short amount of time, but that is an important thing. He doesn't have any beaking at his styloid. He's basically got a scaphoid fracture that hasn't healed. He's got a nonunion.
And you think he came back because somehow or another with the fall he irritated the
It
site of the
hurts.
nonion? Yeah. Yes, because his wife is with him, I give him the talk again, and I don't probably hold back too much. I would say that when we spoke before, I recommended surgical intervention because I'm concerned you're not going to heal, and that will certainly lead to arthritis. I just don't know when. And then if he and his wife agree they still don't want to do anything, then they can go away again, I guess.
So in this situation, if you offer surgery and you're counseling them, how long do you tell them that they've got to really back off on activities? So not just immobilization, but like no doing all the things around the house and the yard and everything that, he wants to do.
So at this point, he has a scaphoid waist fracture, which is minimally displaced, but is a clear non-union.
Yeah,
Um,
not like FDA definition of non-union, but it's a non-union.
yeah, yeah.
And you can actually see a little bit of sclerosis on the X-ray.
I think I would request, I would probably put the 3 month number out there because while I think there's a chance he'll be healed or healing at 8 weeks, and I can tell you how I would think about doing the surgery, but I'd love to hear what you might have done. But I would say 3 months. That would be my answer, even though I hope it would be shorter.
Good. Well, I've been trained well because I told them 3 months of backing off on all activities. I told them we're looking at the better part of 2 months, if not longer, for immobilization. Um, and it's interesting. His wife quoted that number back to me, and when I was talking to her after surgery, saying, "Remember, 3 months. Tell him 3 months." I was like, "Okay, you tell him 3 months too."
So how
So
did you
how would
approach it?
you? Well, I mean, so I wanted to make sure that it wasn't a proximal pole, it was a waist, but just to make very sure, I got some advanced imaging, because I wanted to ensure the viability of the proximal pole. So for me, that's an MRI. Although I think you could get a lot of that information on a CT. I wasn't as worried about pre-op planning for bony alignment, because it was not angulated. There was no humpback deformity, so I don't think a CT was going to add a whole lot in that respect. So I got an MRI, and I don't know if you would have gotten any other imaging, or just gone off of the X-rays, or whether you would have gotten a CT. But the proximal pole was viable.
Yeah, so I would not have gotten any other imaging. And I would approach this dorsally with a small incision. And if I don't have to do any reduction, um, or minimal reduction, then I would have a very small 1 to 2 centimeter incision, and I'd use some distal radius bone graft down the drill hole.
Down the
Um,
drill. Do you take down the non-union and evolution site?
I typically do not. It would have to be, if it was displaced to a visible degree, then I would have to do that. And I still think you can go dorsally as long as you're proximal to the dorsal ridge with the blood supply. But if it's pretty close to anatomical or minimally displaced, or if I can manipulate it, then I would not take it down.
It's interesting. This one was not, there was not a lot of reduction, but it was gapped. So there was a pretty clear non-union gap. I guess I veered from the wonderful training that you gave me and made a real incision, because I was going to harvest distal radius through the same incision, distal radius cancellous autograft through the same incision. In the absence of any, lack of viability of the or question of viability for the proximal pool, I did not think doing something vascularized, either pediculed or something crazier than that, was necessary. I think there are a lot of papers demonstrating now that you can heal many things with good carpentry and not using a pediculed or vascularized graft. So this was cancellous autograft harvested from the metaphysis of the distal radius.
I love it. That's what I would have done. And I'm not against a larger incision as long as you protect the blood supply, but I think you can get away with all of that through a smaller incision. I will
Well,
say
hold on, I want to ask you something
okay.
because people love the technical stuff.
Okay.
So we've had some kind of quick conversations in conference about how to harvest distal radius cancellous autograft. I want to know the Chuck Goldfarb approved protocol of how you harvest the graft, and I can say if I have any differences from that.
For sure. I'll give you that, and I'll give you a technical pearl for the screw. So I make a very small incision, again, 1 to 1.5 centimeters, which is roughly at listers, just ulnar to listers. So it seems a little proximal and may seem a little ulnar, but when you flex the wrist, it's in exactly the right spot. Now, through that incision, I can place my K-wire and place my screw, and I can also retract the skin easily to listers. When I harvest cancellous bone graft dorsally, I make sure to stay proximal and radial to listers, or kind of right at that proximal radial corner of listers. And the reason I do that is I've seen ruptures of the EPL when that is not respected. So in other words, if you just take a rongeur and crunch off listers, I think you can create a little bit of a problem with your EPL. So I don't do that. And knock on wood, I haven't had any problems with the tendons. And then it's just I use a small curette as like a drill, and then a bigger curette to harvest the bone graft. So that's my bone graft harvest technique. How do you do it?
I've heard the cautionary tales from you and Marty and Ryan in conference about, potential compromise of the EPL. I think it is kind of similar to the attritional rupture that you see after a distal radius fracture, with disruption of the metaphysis, bilisters, and potentially a water zone area on the EPL, on the EPL tendon itself. So I actually I make a bigger incision, admittedly, or I'll make a separate incision if I'm trying to be cute with the dorsal wrist incision. And I go under the second compartment. I look at the EPL course and I stay way radial to it and proximal to it. I look for my second compartment because I'm usually mobilizing my second compartment anyway to get access to my wrist. I go under the second compartment. I actually use K-wires to make myself a little window. Osteotomes open up the window. I I found it to be add extra operative time and be a little frustrating, especially if somebody else is doing the scooping and I'm having to watch them scoop through a small window. So I take a bigger window. I allow the trainee to harvest as much as I can, and they can from their side. I inevitably, because I'm coming from a different angle, I remind them that I'm going to harvest more than they did, and we harvest a fair bit. And then I put some gel foam into the area where I've harvested in a metaphysis, mainly for make me feel better potentially about hemostasis. And I try to close the cortical trapdoor if I can, not close it, but to put it back down. Although I don't think that's a critical part of it.
So, listeners, this is a fundamental difference between Chris and myself. I go for simple, effective, and fast, and Chris goes for expensive, time-consuming, and elegant.
Yeah, well, I don't think that gel foam is very expensive, and I have no conflict of interest with gel foam. I'm actually not sure what the non trade name for gel foam is.
I don't know either, but I do know the cost, and you're right. It's far less expensive than I thought. And let's just say, so I don't get anybody in trouble, it's less than $20 for a small piece.
I think it's $17.18 based on the reports that we get, something along those lines. But so then for the interested why you would only pack through or put the graft through the screw site, because I find that to be an incredibly frustrating exercise, which I don't know how much actually gets down there. And so while I used to say that I do that, I've stopped doing that, and actually just for this particular case, I packed it into the actual non-union site.
So this is important. Did you stop doing it because you had failure for those fractures to heal, or you simply didn't feel good? And I don't mean that in a judgmental way. You didn't feel good about the fixation when you packed bone graft down the tunnel.
It wasn't a fixation. I just don't know how much of the graft actually ended up in the tunnel versus, being extruded into other non-scaphoid parts of the wound.
Yeah, I don't know what to say to that. I think when I look at I first of all, I think
But
the drill.
how do you do it?
Well, I think the drilling is the main thing you're doing, because when you
Of
drill, and
course.
especially if there's a cavity, that's the main thing you're doing. And then I think, the to talk about trade names, Acumed and Accutrack has a little plunger which is designed for this. And so once you've drilled, you pack your cancellous bone graft into the tunnel and use the plunger to push it approximately, to the site of the non-union. And theoretically, it should expand there. Of course, you're right. I don't know for sure, but when you look at your X-rays, if you do have a cystic lesion and you do this technique, and then you look at your X-rays, there's bone graft which fills that cyst. So I feel pretty good about it. And I don't think there's any relationship between technique and healing of these fractures, because honestly, it's typically about putting the screw in the right place and the kind of stability one achieves, as much as the bone graft may add something.
Yeah, I think it's the carpentry more than anything else. And the fact that you're drilling across a fracture that, this particular case, I mean, you think about why things go on to non-union, kind of basic bony principles. This was because of lack of immobilization. This wasn't because of lack of biology, kind of roughly when you look at contributors to non-union. Um, and that's usually the case for some of these, scaphoids that you're treating that haven't healed because of they haven't had adequate stability. When you use that plunger, do you have to take out your guide wire?
Yeah, the guide wire is, I mean, now, if you have an unstable fracture, then you obviously need a derotation wire to keep the scaphoid where you put it. But you take out the guide wire, and thankfully generally don't find it to be a problem, especially because you hadn't taken down the non-unions. You don't have rotational instability.
So this one was gapped, but it was really kind of almost a plate where it lies if you were able to compress it. So, for this one, I actually put an accessory wire outside of the path of where I thought I was going to put my wire for my screw, so it would stay out of the way. And then actually, like you're saying, I was very careful not to go to the dorsal ridge or to get onto the radial side. But I localize it on, because when you have a non-union, it always still looks like bone. But then, if you can, I use the fluoro to localize where to start evaluating the non-union site. So I was able to find the non-union sites, and I actually used the curette and kind of tried to freshen things up because I knew based on the imaging that I had some sclerosis there. And then being very careful to respect the dorsal ridge, but working underneath from that kind of window that I had to curette as much out as I could on both sides of the fracture.
And what I think you're saying, correct me if I interpreted it incorrectly, what I think you're saying is when you look at the scaphoid, you don't see the non-union, right? Because the cartilage cap is intact. And so you need fluoro to decide where to cut the cartilage.
Right.
Is that correct?
Exactly right.
Yeah. And the technical pearl is only stated because I've done this incorrectly, is when you think you're going to get compression, and whether that be from a volar approach or a dorsal approach, you have to be really careful not to place a screw that's too long. Because if you place a screw that's too long, and let's consider from a dorsal approach, then your screw can essentially run into the distal cortical bone of the scaphoid, or go past it if you've drilled through it. And if you do that, you may not get compression. And in fact, you may fix it with a gap. And so it's important that you allow the screw, which is compressive, to compress the bone.
Right. I think that's a great point. And you've mentioned before, this is not a screw typically where you're obsessed with being center max distance. The orientation of your screw matters a little bit more. Is that right?
I think it does. And I don't know whether, I like center and I like perpendicular to the fracture line. And if you can get both, great. But sometimes you're kind of sort of playing both at the same time.
Right. And I think that, which one do you think is more important?
I don't know. I'd probably say center, but I'm honestly not positive. We know those oblique fractures are the toughest to get to heal. So it was funny because David Brogan shared with me some images for a talk I gave in his technique when he uses the vascularized graft from the knee. And in those cases, he is absolutely putting his screw in perpendicular with the graft and the scaphoid. So it's I kind of think center is more important, but I don't know that. I don't know that to be true.
So, I mean, I packed in a bunch of the graft through this non-union void while I had my, essentially a derotational stability wire in place, so as to not take something that was stable and make it unstable. That's why that wire was important. Packed everything in, and then put my wire in for my main screw and put my screw across, got it lined up well, seemed to compress a decent bit. Do you ever put two screws in?
Oh my God, that's heresy. I would never put two screws in. Tell me why you put two screws in this one.
Honestly, big guy, big scaphoid, there was room. And I kind of had this talk with him that, if this were to go on to not heal, and we're not going back, because of, you take somebody, you immobilize them for the better part of 3 months, and tell them not to do stuff. If it's not healing well, you're going to keep them immobilized a little longer. He probably wouldn't want to go on to to a revision surgery and prolong. Basically, it's more time out of their life. And if they're going to end up getting a snack wrist, they'll deal with it then. So, I actually said there's room in here, and, with the screw system I was using, there was adequate range in terms of, being able to sneak in a smaller screw. So I put a smaller screw essentially very close to the path of that original derotational wire.
Yeah, it's nice when you get your derotation wire, it is a perfect path for a second screw, and almost always that's the smaller version. Theoretically, if most systems have three three sizes. And I typically use the middle size for my scaphoids, with the possibility of upsizing if there is a non-union. But I love the idea of putting a really small one in a mini in as your standard screws.
Yeah, so I mean, that case, went well. Talked to the wife afterwards, and she was like, make sure you tell him 3 months, like I said earlier. So interesting. I was sharing this case with our partner David, who you just mentioned, because we were doing some other case together, and he's like, well, it's going to make it really hard for that MFT. I said, well, there's not going to be an MFT. There will be no other attempts of fixation. I said, if this doesn't do it, then that's it. But I honestly, I'll feel good evaluating him, knowing that I've got really solid fixation. And we'll obviously get the CT scan that we had talked about. When do you get that post-op CT?
It's funny, I just had this conversation because it's a really important question, and it depends a little bit on the patient. I don't want to, and I try to be sensitive to cost. I don't want to get two CT scans, so I don't want to do it too early, but also don't want to wait too long and lose time for the patient. So for most patients, it's at the 8-week mark. There is a great paper from the European Journal which described a protocol in which non-surgical treatment was chosen, and an early CT at 4 to 6 weeks was then obtained, and if there wasn't healing, then they did surgery. I think there's lots of ways to think about this, but with a surgically treated patient, 8 weeks is sort of my hallmark, give or take. What about you?
Yeah. Yeah, I think that's a very different decision-making context, when you've gone initially the non-operative treatment. And certainly, like you said, you want to make sure you're avoiding extra cost and radiation, with the extra CT. So the number I was going to put out there was 8 weeks as well. Because I usually see them at the 6-week mark, and I'll order the CT for a couple of weeks later. So that I have a sense. At the 6-week mark, I'll probably keep them in a cast, do the CT scan in a cast, and then call them with the results of the CT. And if it looks okay, have them come back and have the cast removed and start therapy. If it doesn't look okay, at least I still have a cast on there.
Yeah, I think that's very reasonable, and yeah. And then my goal is, if they're healing but not healed, then I just get a little more aggressive with therapy, so that again we're maximizing motion and even strengthening while fracture healing is making its way. So if we have reasonable healing, say it's 25% or something like that on the CT scan, I don't repeat the CT scan. I just continue to follow one or two more x-rays and make sure they're clinically doing well, make sure they're functionally doing well, and then I just let them go. Do you repeat the CT?
Typically not if the first one shows, that we're well on our way. I don't know if my threshold is probably a little bit higher in terms of percentage healing than 25%. But in this particular case, I'm sure that fine osseous detail will be obscured by metal artifact. Clinical correlation will be recommended.
We're counting on that.
So yeah, I think this has been a good discussion. We've covered topics from firearm violence to trank to camping to scaphoid nonunions. I'm pretty sure we could save the articles for our next episode, because I think that we probably lost a lot of people along the way this far along.
Yeah, I think I'm looking forward to the articles because I think they are a good segue to a more generalized discussion. So I look forward to that. And thank you. It was fun catching up.
Absolutely. Have a wonderful day.
All right, you too. Trying to stop it.